Good morning, class. It's good to be back with you. As you can see, we've left the 90s. I'm back in my own little virtual paradise. I'll be lecturing from the beach today for you. So we're going to be moving into the very first cancer slide series. And so this is going to be back talking about the background of cancer. Give me a moment while I share my screen and we move into the PowerPoint. Okay, well, we'll be talking about the background biology, the classification, the development of cancer this morning. So cancer is lots and lots of different diseases, and each one presents differently, depends on the part of the body it's in, the cell that's been affected. So this is over 200 diseases, and realize really they all have a common characteristic. They all have unregulated, uncontrolled cell growth of an abnormal cell. It affects every demographic group, every cultural group, every age group. Cancer is no respecter of person. There's over 15.5 million Americans with cancer right now, and there's usually about 1.7 million new cases diagnosed a year. This data has been around for several years, but since 2018, 2019, the numbers are staying fairly consistent. So what's in your edition of the textbook is the same as what's in the 2020 edition of your Lewis textbook. And the Cancer Society has posted similar statistics. So this is relatively stable in our country. We're good at diagnosis. And so you just need to remember, there's probably 600,000 Americans are going to die of cancer every year. We worry about the COVID virus numbers, but when you look at these numbers, if you think there's 15.5 million Americans that have cancer and 600,000 are going to die annually of this. So there's so many diseases that are also equally dangerous to us. It's just, this is not as infectious. So cancer incidences of lung, colorectal, and oral cancer are on the decrease. Lifestyle changes and our knowledge of what causes them have increased. So people are actually purposefully changing lifestyle and doing primary prevention. So we're getting a decreased incidence, but other kinds of cancers are still on the increase. Non-Hodgkin's lymphoma and the skin cancers are two examples. The American Cancer Society has produced a CAUTION acronym, C-A-U-T-I-O-N, to just kind of help us recognize the common signs of cancer. So the C stands for change in bowel and bladder habits. A sore that does not heal. U, any unusual bleeding or discharge that's not normal for you. T, a thickening or lump anywhere, but especially breasts, testicles, on your body. I, if you're having persistent indigestion and difficulty swallowing, and that's not, doesn't mean like you went out and you ate a Mexican dinner and so you have indigestion. It's persistent, ongoing, almost every day, indigestion and difficulty swallowing. Obvious changes in color, size, shape of a wart, a mole, or a sore on your mouth or other mucous membranes, a nagging cough or hoarseness. Usually we say that persists for longer than 4 to 6 weeks. Some say even up to 8 weeks. So this is just a chart. This chart talks about how many new cases of each kind of cancer we typically see in a year. As you can see, the diagnosis of prostate cancer for men and breast cancer for women, those are the most prominent and prevalent cancers, followed by lung and bronchus for both genders. Back in the 1960s and 70s, lung cancer was a men's disease, but then we had the onset of Virginia Slims, the first cigarette marketed for women, and we've come a long way, baby, which was their advertising slogan. And now we've equaled men in it being our number 2 cause of cancer. There's other causes of lung cancer, but primarily smoking. And you're going to hear me get on that soapbox all day today with every lecture I do, because smoking is the number 1 initiator and progressor of cancer. It's such a dangerous habit. As you can see, colorectal cancer is number 3 for each age group. And then if you look through this list, you'll see skin melanomas, non-Hodgkin's lymphomas, leukemias. If you look at the cancers that we're studying as exemplars: breast, prostate, colon cancer, lung cancer, leukemia and lymphoma, skin cancer. These are cancers that are on the list of the top diagnosed cancers in our country, and that's how they made the exemplar list. This lists the cancer by mortality. The earlier slide was incidence. How many are we going to diagnose in our country? This is what cancers kill us, because we're getting better at treatment for a lot of cancers. The number one cancer killer in our country is still lung and bronchial cancer. And if you look at those numbers, 25 to 26% of all cancer deaths are from lung and bronchial cancer. So that cancer is far and by wide the most dangerous one that we deal with on an ongoing basis in our country. Yes, prostate and breast kill us, but we're better at that. Those were our number one diagnosed, but they're down to just 9 to 15% of the deaths as compared to 25% from lung cancer. Then after that, colorectal, pancreatic cancer, and on down the list. Cancer seems to be more prevalent in men than women. We know that African American, Black people have a higher incidence than whites and other minority groups. Cancer is the second most common cause of death in our country. Heart disease is number one. Cardiovascular disease, that's heart, stroke, peripheral vascular. Cardiovascular disease as a global package is our number one killer in our country. In the United States, we have a 5-year survival rate of 85%. The 5-year survival rate is kind of like an arbitrary number that the Cancer Society chose, and the diagnosticians, epidemiologists that work with this have chosen. If you can make it to 5 years, then that you have a better instance of long-term survival. So a 5-year survival rate is kind of like a measurement, a measurement that we're specifically looking at. So what we're looking at is somebody who is either disease-free, in remission, or getting ongoing treatments for cancer, but they've made the 5-year mark with active cancer. And so it's 85% in America. Those are pretty high numbers. So cancer comes from stem cells. Most cells in our body have undifferentiated stem cells. And you take that all the way back to, you just finished reproduction and genetics and some of those other topics in Professor Hunsaker's section. And within that, you talked about maybe stem cells from the fertilized ovum. And out of those stem cells, it gives rise to normal cell structure. But at any time, those stem cells can mutate. So the predetermined stem cells grow up and become highly differentiated, mature cells that do the job they're supposed to do. But and this is a picture on this slide of the normal life cycle of a cell. There's a Z0 resting stage. All cells go through a resting period. And when that cell needs to multiply, then they enter the active cell cycle and they go to G1, G2, G3, and then all the way to M, the mitosis stage, and where they actually divide. It's not so important you memorize this. You guys did this back in biology, A&P. This is stuff you know. You should remember that when it becomes metabolically active, the RNA and the DNA are being synthesized in the cell. And then when it enters the mitosis cell stage, there's cell division. You can see the spindles go to the opposite end of the cell. The RNA and DNA are split, and it becomes two daughter cells with matching DNA. And the RNA makes the other half of the DNA, matches up to make the other half of the DNA helix in the new cell, and that's the growth of new cells. So each cell looked like the parent cell before it. Some cells are permanent cells. We don't regenerate heart cells and nerve cells on an ongoing basis. My heart cells last a long, long, long time. We may have some new growth of cells, but it's not a continuous every 100-day replacement of cells. So cells that are more metabolically active are more likely to develop cancer. So skin, mucous membranes, the parenchyma, and the lining of our lungs, cells that regenerate. As compared to, you don't hear about heart muscle cancers as often as you hear about skin cancer and mucous membrane cancers. So this to keep in mind, the cell life cycle has a lot to do with cancer growth, progression, and even the treatment. We're going to come back to that on the next set of slides. So all cells have a predetermined life cycle that come from the parent cell. So if you put those cells in culture medium, they all kind of grow the same. A lung cell grows like a lung cell, a skin cell grows like a skin cell. They're either columnar epithelial cells, or they're different various types of cells. But cancer cells, when we take those cancer cells, put them in a petri dish, they don't stop growing and they don't act like the parent cell. They have unregulated growth that grows on top of itself and overlaps. They'll even grow out of the dish if we allow them to grow unregulated. Most cells, when they hit walls, they have contact inhibition. Cancer cells don't have that. You think about it in your own body, when the heart grows to a certain size, it butts up against lungs and chest wall and bones and esophagus, and the heart kind of goes, okay, this is as big as I'm going to be. Same thing happens with the liver, same thing happens with the lungs, same thing happens with the spleen. It kind of goes, okay, this is my size, I button up against other organs, I'm stopping growing now. Cancer cells don't do that. When they butt up against walls of muscle or tissues that belong to a neighbor, they go, that's nice, I'll just move in. And they take over and continue to grow. So cancer cells also respond differently to the signals in the cell. We have signals that are produced by various genetic factors in our body that say, it's time to grow, it's time to stop, it's time to divide, it's not time to divide. Cancer cells respond differently to those signals, and they just continue to divide indiscriminately. One of the most overlapping theories of cancer developed at this time, and we've come such a long way. When I was in nursing school, we didn't know any of this, but we realized that stem cells, those baby cells that differentiate to become mature cells, are where the origin of a lot of this happens. So a mutation in a stem cell anywhere in your body, remember stem cells are in bone marrow, they're all over our body in each cell group. When you're in a rapid growth cycle, those stem cells are the baby cells that turn into the fully matured adult cell. And what happens is that during that stem cell growth, a mutation occurs, and that damages the DNA. And so every daughter cell after that has that damaged DNA. Some of that damaged DNA can become cancer. So once mutated, that stem cell is mutated and it becomes a different type of cell. Once that happens, the cells can die from damage, because sometimes they go, oh, wait, I'm an abnormal cell. And so there's a pre-programmed apoptosis, cellular suicide. And the cell goes, okay, I'm not normal, I'm just going to go away. Sometimes we can recognize the cells are damaged, and sometimes we can repair our own cells. Our body has a lot of ability to take damaged cells and go, you're not quite right, I'm going to clean this up a little bit, kill off a little piece, grow up something else. Or those cells, those damaged cells, can continue to divide. And if they continue to divide and they're mutated, those are the cells that are likely to become malignant. Remember, at that point, we're just talking about one cell that's divided to two cells. A 100 days later, they've divided to 4 cells. We're not talking about very many little microscopic cells at the time of mutation. There's some terminology you need to be aware of. You see these in lab reports, and I think it's very good for nurses to sound intelligent, know how to read pathology reports, to have an understanding of what's going on. So when they read something, they can better communicate to the patient, they can communicate more effectively with the providers, and we can sound like the intelligent, educated healthcare providers that we are. So the term differentiation, that is a more specialized, more mature cell. I have a highly differentiated cardiac cell. It looks and acts like a heart muscle cell. I will have a highly differentiated oral mucous membrane cell. It looks and it acts like the oral mucous membrane lining in my mouth. I have a highly differentiated lung cell. It looks and acts like a wall of an alveolus. That's what it's supposed to be. So those are highly differentiated cells. Okay, so it's important for you to remember highly differentiated from poorly differentiated. So aneuploidy, A-N-E-U, nucleus. You think in the nucleus of any cell, that's where the DNA is. So aneuploidy is an abnormal number of chromosomes on your DNA, deoxyribonucleic acid. So an aneuploidy is an abnormal number of chromosomes. Hyperplasia means we have more cells, but they're normal cells. There's an overgrowth or more normal cells. You've read in lab reports a hyperplastic heart, a hyperplastic liver, a hyperplastic pancreas, or something that's enlarged. Metaplasia is when we have a fully differentiated cell that was trucking along, and all of a sudden, well, let's see, let me rephrase that. So I have a fully differentiated cell that looks and acts like, I'm going to use the most common example of metaplasia I can think of, and that would be endometriosis. And that's where endometrial lining of the uterus gets out of the uterus and lands on an ovum or a rectal colon wall or the surface of the uterus. And so it's a highly differentiated cell. It says, oh, I am uterine lining. So every month when the body cycles in response to hormones, the uterine lining becomes inflamed and it changes its structure, and it's meant to slough out through normal menstruation. But if it sits on the surface of the rectum or on the surface of the ovum or on the surface of another body organ, just the inflammation causes pain and problems, and we have endometriosis. That's metaplasia, a fully differentiated endometrial cell where it doesn't belong. So you end up with a uterine cell on the wall of the colon. That's metaplasia. Another word we use is dysplasia. It's alteration in the size and shape of a highly differentiated cell. Sometimes we can remove the irritant that caused it, whatever the causative agent was, and it can go back to normal. So I'll give you another example of that. Dysplasia, sometimes women get yeast infections, as you know. If somebody came in for a pap smear and they had a minor yeast infection, or they had recently had sexual activity, these cells on the cervix might have some dysplasia. They might be a little abnormal from inflammation or a little damaged, but once the irritant's removed, you give it a couple of days, the yeast infection goes away, they've rested those tissues, the irritant's removed, the cells go back to normal. So the dysplasia passed. Anaplasia is when a normal cell regresses to an undifferentiated cell and it does not look as normal anymore. This is bad. If you get some kind of grading or staging from a histology report, whether it was a pap smear or some other report, and you see hyperplasia or metaplasia, those are not as bad. But if you see anaplasia on that report, that means the fully differentiated cells have regressed. And now we have a lot of undifferentiated cells, cells that don't know exactly who they are and are not acting normally. That's bad. That term means, ooh, let's watch for cancer. Another couple of terms we're going to talk more about on the next few slides: genotoxic carcinogens and promoter carcinogens. Genotoxic carcinogens are the original originating substance that caused the initial alteration in the DNA. It's the thing that mutated the cell to start with. Then the promoter carcinogens are the things that with prolonged exposure continue to progress that cancer and encourage its growth. So some of the things do both. Cigarette smoke, sun exposure, ultraviolet exposure can do both, but there's a few differences. We're going to talk about this in a minute. So when normal differentiation, the cell progresses from a state of immaturity, the stem cell, to a fully developed mature cell, and it's stable and it doesn't change and it does what it's supposed to. We don't know how it happens. We don't know everything there is to know about it, but we see it happening every day in every patient. This is this is a chart. I can't remember if this came out of your textbook. I think it's in your book. But it talks about how once the ovum's fertilized and you have these little baby stem cells, they divide into endoderm, mesoderm, and ectoderm, and each of those differentiate to become endoderm, becomes lining of the epithelial, tracheal tissue, lung tissue. The mesoderm becomes muscle tissue, bone tissue, other cartilaginous connective tissue. The ectoderm becomes brain, skin, your other glands in your body, adrenal glands. So that's kind of the process of differentiated cells in normal growth and development. Carcinogens cause that early DNA to mutate. So we can have an initiation. That's the time when the exact damage to the DNA occurred. And then it promotes, which means we get repeated exposure to whatever damaged the cell, and the damaged cells continue to grow. And then progression is when it actually engages in aggressive malignant activity. That would be when it invades, it takes over the organ, when it metastasizes to other organs and begins to expand in the body. So we know that all three of these things happen because of an original damage to DNA and a problem with our immune system that didn't recognize that damaged cell and get rid of it. So we know that within genes, we know that we have, you guys understand, DNA, chromosomes, genes, right? So in that system, there are something in every one of our in every one of our chromosomes called a proto-oncogene. These are genes that normally regulate cell growth. These are good. We want proto-oncogenes, okay? If they mutate, cancer can happen. We also have a gene called a tumor suppression gene, and they suppress the growth of abnormal tissues or even normal tissues when they get to a certain point. So proto-oncogenes regulate the cell processes that make our cells grow. Tumor suppressor genes shut down cell growth when it needs to. So if proto-oncogenes mutate, they become what we call an oncogene. If a proto-oncogene mutates, it becomes what we call an oncogene. Just because you have an oncogene doesn't mean you're going to get cancer, but it sets up the process for cancer to develop more easily. That's really bad grammar, but it sets up the process for cancer to develop. Okay, so you get the point. Proto-oncogenes, normal, we want them. They keep our cells functioning. If they mutate, if those genes mutate, then the oncogene it's damaged and it can cause abnormal growth in the cell. And we also have those tumor suppressor genes that regulate our cell growth, slow it up and stop it. But if they mutate, then the suppression of those abnormal cells isn't going to happen. This is pretty common. A tumor suppressor gene that's damaged is a very common causative agent, a causative factor in breast cancer, brain cancer, and muscle cell cancer, sarcomas. All right. Tumors then are classified as benign tumors or malignant tumors. Just because you have a tumor doesn't mean you have cancer. A tumor is an abnormal growth. Neoplasm means new growth of tissue, new growth of tissue. If it's benign, it's not as dangerous, right? Lots of people have tumors. Lots of people have little lipomas. Lots of people have benign growth. Benign tumors are well differentiated, which means the tissue still looks and acts like the parent cell, and it's doing what it should be doing. It's growing abnormally. They're encapsulated usually, which means they're regulated. They have a wall around them. They don't break off and fragment off and metastasize to other tissues. They are generally expansive. They will just continue to grow. You've heard people say, well, I had a 2-pound benign tumor taking out of my abdomen. So it was big, but it wasn't invading the other tissues and it wasn't acting badly. It wasn't a bad teenage cell. It was just a really big cell, group of cells. Benign cells look like the parent cells. They don't invade other tissues. They don't metastasize. And if we take them out, they don't generally reoccur. Whereas a malignant neoplasm is usually ranged from differentiated to really poorly differentiated. And they are able to metastasize. They break off. They travel to other places in the body. They invade other tissues. They're infiltrative. They move into other tissues and take over. They also have expansive growth. If we take some of it out or all of it out, they still recur. We miss cells. It will recur somewhere else. They are not encapsulated. They're loosely attached and can break apart and invade. They look a lot less like the parent cell, and they don't act like the parent cell, and they don't have contact inhibition. So when they butt up against something next to it, they just invade it instead of stopping their growth. So here's just a side-by-side benign versus malignant cells. So benign tumors, again, cohesive, well-defined borders, slow growing. They push through other tissue, but they don't invade it. They're encapsulated. They don't recur if we take it out. They have normal nucleus. They're well differentiated. Malignant cells are invasive, not cohesive, rapidly grow, metastasize, meaning they break off and go to different sites. They are irreversible, and if we take them out, they will probably reoccur. They have a large nucleus. They're highly undifferentiated. And this is cool if you like cancer. Cancer cells have the unique ability to engage in angiogenesis. So when they break off and move to a new place on the body, they have the ability to develop their own blood supply. They attach to the current capillary system and create their own blood supply, whereas most cells can't do that. Okay, so cancer, what causes it? What develops it? Well, there's a lot of different cancers. We know that some come out of genetic changes, some come out of chemical exposures, some are environmental exposures, and viruses are bad at causing cancers. So viral causes and immunologic suppression, other immunologic causes. And they were always looking for new causes because it's an ongoing field of study. So at the point of initiation, the original parent cell, that target cell that's going to divide, is exposed to a virus, a hormone, radiation, a toxic chemical, a genetic factor from birth even, and it changes, mutates that cell, and that mutated cell just kind of goes through its life. But when it gets ready to split, it creates two cells, and now you've got two cancer cells. And they're going to continue to proliferate. Promotion substances, if you continue to expose that substance, those cells to that substance will continue to grow and grow and grow until it's promoting is continuing the mitotic rate. So it's mitosis is happening. Progression is we actually get to the point where we have enough cells, and we're talking like 1 billion cells before it's identifiable to palpation or even on some x-rays, and that we're at a clinically identifiable place, and it continues to grow. So initiation, promotion, and progression. Initiation, the original mutation of the genetic structure, and it will clone into two different cells. Interestingly enough, some cancer cells, when they mitose, can make 3 cells. They don't always just do 2. Sometimes that massive growth process of them can make more cells. Those would be rapidly dividing tumors because exponentially they're growing faster than just normal cell growth. But the mutated cell has the potential to develop. It clones itself, and then daughter cells are more neoplastic cells. So once initiated, that mutation is irreversible, but not all of them will become tumors because some of the tumors are identified by our immune system. We'll come back to that in a minute. So if they have the ability, if they haven't damaged themselves too much, they will continue to grow. Some mutated cells now become unable to replicate. That's actually a good thing. So once we've initiated it, okay, let me rephrase. What's causing that initiation? We talked about genetic factors, but also chemicals, radiation, and viruses that I mentioned. Some carcinogens can be detoxified and harmlessly excreted. Some are not so easily detoxified. So, and once a cell's been exposed, sometimes those cells self-repair. Sometimes they die off because they recognize, wait, I'm not healthy and normal. I'm just going to do apoptosis, cell pre-programmed suicide. And then again, some grow. The ones we're talking about in cancer are the ones that grew. So chemical carcinogens are chemicals that cause that structural change in our cell. They're a little harder to identify because it's not usually just an isolated exposure. It's an ongoing exposure. So we like, okay, what were you exposed to? What have you taken? So, but how do we know? How do we know that it was that exposure? So it takes a long time to identify this. We have to have large population groups of studies. Sometimes something that causes cancer in a laboratory animal, like a rat, might not cause cancer in a human. So we can't always translate that research study. We also know that some drugs that we give are chemical carcinogens, especially immune suppressant drugs. So there's some drugs that we give that can cause cancer later for our patients. We'll talk about that in leukemia, of course, and we'll talk about it with respect to a couple of other things in the future. So radiation, another carcinogen, genotoxic carcinogen that started off this cancer process. Ionizing radiation, like you'd find from a nuclear bomb or even from from some of our X-ray procedures in the hospital, can cause cancer in almost any human tissue. We don't know what dose causes it. We know higher doses are more likely to cause it. Ultraviolet radiation from the sun, we have already said that it's likely to cause basal cell, squamous cell, and malignant melanoma in the skin. We know this. That's why we use sunblock. It blocks the ultraviolet radiation. I'm on my virtual paradise beach. I need to remember to wear my SPF 15 or higher. Okay, then viruses can be carcinogens. Certain ones are more common carcinogens than others. So the herpes family of viruses, 1, 2, 6, all certainly tied to cancer growth. Cytomegalovirus has been linked to prostate cancer and Kaposi sarcoma, which is a skin and connective tissue cancer found commonly in HIV patients. Epstein-Barr is Burkitt's, commonly linked to Burkitt's lymphoma. Epstein-Barr has also been linked to another lymphoma, Hodgkin's disease, which is another lymphoma. So papillomavirus, you guys just got through studying this when you were studying reproduction and sexuality. HPV is human papillomavirus, and that has been tied to cervical cancer, penile cancer, and laryngeal cancer. It's also been tied to malignant melanoma. So the vaccine that we give to young men and young women to prevent papillomavirus is primary prevention for some of these cancers. A lot of cervical cancers, 90-something%, are linked to HPV. Human T lymphotropic virus, HTLV, has been tied to T-cell lymphomas, hairy cell leukemia, Kaposi sarcoma, all different viruses. Viruses act differently than bacteria. Bacteria are their own little living organism that just multiplies in your body. Viruses are fragments of cells that move into your cell, attach to the DNA of your cell, and reproduce. That's why they're so known to cause mutations and cause cancer. Bacteria don't move into my normal cells and change my DNA to do their own bidding. Viruses do. Okay, so we just talked about most of these. So drugs can be carcinogens. A lot of them are genotoxic, and they also can be promoters. So we were exposed to them, it damaged our genes, but then we kept taking them, it promoted our genes. Cocaine, heroin are two commonly taken substances out in our society that can change that DNA and continue to promote it if you continue on it. And most people who are doing heroin or cocaine didn't do it once and stop. Quite often these are repeat users. But there's some other things. Bisulfan, that's a drug category. Diethylstilbestrone, estrogen, those are things that can initially cause damage and then promote it. I think when you were talking about estrogen and progesterone birth control pills, you talked about how the estrogen-related birth control pills are more likely linked to breast cancer because it's a carcinogen. Chemical agents. These are common things we have in society. Hydrocarbons. Those are methanes, propanes, butanes, the propane, petroleum products. Arsenic. You think, I'm not getting exposed to arsenic, but you'd be surprised how many chemicals are found in things like carpet and draperies and things where we are getting microscopic exposure to things. Benzopyrene, which is an abstract chemical that we find in things like smoked meats, barbecued meats, found in a lot of tobacco smoke, air pollution has a lot of that kind of substance in it. Saccharin. Back in the 60s and 70s, our diet drinks were sweetened with saccharin. That was kind of the original artificial sweetener in diet drinks. And then we discovered, whoa, it's a carcinogen. And so we got rid of the saccharin drinks and we replaced it with other artificial sweeteners. But who knows in 20 years what we'll find if those do, says the teacher who drinks a Diet Coke every day. Okay, so, these other chemical agents that we see throughout our society in a variety of different things. Nitrosamine is also found in cigarette smoke. Physical agents that can cause active changes to our cells are the radiation things, solar radiation, ionizing radiation. Radon. So let's look at some cancers and what carcinogens we know are tied to those cancers. So lung cancer tied to tobacco smoke. Pleural cancer tied to asbestos exposure. You've seen the commercials. Do you have mesothelioma? Were you working in a shipyard, in 1980? You then contact us, the law offices of whoever. Pleural cancers, that's the lining, the exterior lining of the lung, right, in the pleural space between the lung and the chest wall. Esophageal cancers, tobacco and alcohol, especially tobacco and alcohol together. That's the same true, well, we're going to talk about that also with some of these others. Laryngeal cancer is true for that too. So esophageal cancer, tobacco and alcohol. Gastric cancer, smoked meats, pickled foods, highly salted foods have been tied to stomach cancers. Colon cancer, asbestos exposure and a high-fat diet, obesity has been linked with gastric cancer. Kidney, tobacco and phenacetin, which is a drug we give. Tobacco, if you look at this, tobacco for lung, oral, esophageal, kidney, bladder, liver, and skin. All the major cancers, all tied to tobacco use. All right, kidneys to tobacco, you think of the chemical exposure to the glomerulus as it crosses through that in the microfiltration as the urine is filtered. And then also bladder cancer, because when the urine is sitting in the bladder with the toxins from the cigarette smoking that have been absorbed by the body, it exposes the bladder wall to those same carcinogens. Prostate cancer's been linked to cadmium batteries. Those are the little baby batteries that we have, the little button batteries. Liver is tobacco, alcohol, of course, aflatoxin. Skin, arsenic, coal tar, mineral oil. Those are a lot of those are chemicals. Coal tar pitch, mineral oil, those are all petroleum distillates, so they're hydrocarbons. Bone marrow, been linked to tobacco, and the immune suppressant agent cyclosporine, which we'll talk about next semester. All right, so promotion. This is things that keep promoting those cancer cells. Don't allow them to engage in cellular suicide, or don't allow our immune system to pick them up and promote the growth of these cells. Things that are promoters: obesity, smoking, alcohol use, and high dietary fat intake. Interestingly enough, they're reversible. You don't have to keep doing them. So if you don't, then they won't continue to promote cancer growth. So when cancers first, from the original mutation to the period of identification, it can be anywhere from 1 to 40 years because of the doubling time of cells, how long it takes those cells to grow. The mitotic rate of each type of cell is different. So if it's a fast growing cell, then the latent period is shorter. If it's a slow growing cell, it's a longer latent period. It's also due to a lot of environmental factors and how much ongoing environmental exposure to promoters we have. So a tumor has to get to a critical mass before we can ever identify it. It has to get big enough to find either on mammogram or x-ray or by palpation. So a doubling time is something we talk about. This is a term that's going to come up more than once in this lecture. A doubling time is the time it takes for that tumor to double. So a 100-day doubling time is kind of an average doubling time for a lot of cells in the body. Every 100 days, the cell splits into 2 cells. You think our blood cells have a 120-day doubling time. So that's just blood. So other cells are 100-day, like mucous membranes. Just depends on what we're looking at. So we'll take a 100-day doubling time for an example. So a tumor with a 100-day doubling time, so day 1, it turns to a abnormal DNA. 100 days later, it doubles to 2 cells. 100 days later, so we're 200 days out, it's 4 cells. And it's going to double every 100 days. So from the time of the first change, it will be 10 years before it's 1 cubic centimeter, and then it's clinically identifiable. It's a 1/2 inch. We can palpate that. We can see it on x-rays. At that point, it's got about 1 billion cells. So it took 10 years to get to 1 billion cells. But you think with a 100-day doubling time, in 100 days, it's going to have 2 billion cells. In another 100 days, it's going to have 3 billion cells. So that 1 cubic centimeter tumor that took 10 years to get to 1 centimeter, at 11 years, it will be 8 centimeters. That's 4 inches. So progression of cancer is affected by the growth rate, how invasive and how quickly to metastasize it is. For most cancers, the most common sites of metastasis, lungs, brain, bone, liver, and adrenal glands. Those are always metastatic sites we start looking for. Lungs, brain, bone, liver, and adrenals. This just talks about the pathogenesis of cancer metastasis, little chart that's right in your book. I just think sometimes the pictures, if you're a visual learner, can help you. You understand how the tumor grows and then it butts up against the wall of its own tissue and it branches out. And so it breaks off and it enters the bloodstream and it travels, it detaches and travels down the bloodstream where it sets up in a new tissue and it develops its own angiogenesis, its own blood supply, and it continues to grow and propagate there. So that's just a sign where it can transfer and it might end up in the heart or the lung or some other cell. Okay, so the metastasis starts with rapid growth. That tumor starts to grow, doubles, develops its own blood supply, and that angiogenesis is critical. I keep saying that. There's some things with drugs. Some drugs stop angiogenesis. Some drugs slow the doubling time. Each drug acts at a different stage of the cell cycle with a lot of our cancer chemotherapies. So these terms, I keep using them so when you get into the pharmacotherapy, the lab work, and some things that'll make more sense to you. So they develop their own blood supply, and then it's loosely attached. Remember, cancer cells are loosely attached. So these outer layers of cells are easily broken off and can invade and move into surrounding tissues. They can invade lymph nodes and travel throughout the body through the lymph path. And that's why one of the things we always look at is lymph node metastasis in the area next to that tumor. So wherever we find the initial cancer, we always start looking at the lymph nodes near and around that. Also, it can break off into the blood supply. The immune system's job is to say, oh, look, an abnormal cell, let's get rid of it. Let's get rid of it. But sometimes our immune system is inadequate to find and eliminate those cells. Every type of cancer cell, we haven't found all of these, but we know that cancer cells, I shouldn't say every type, most types, have their own antigens on the surface. Remember, every cell has an antigen on the surface. Blood cells have Rh factor A, B, so that helps us to identify blood factor from the antigen on the cell. When you inhale something that you're allergic to, it's the antigen on that cell that triggers the histamine response. So that surface antigen from invading proteins is what our immunologic system recognizes and says, ooh, fight that, get rid of it, we don't like that. So the cancer cells have changes on their cell surfaces. These are tumor-associated antigens. So here's a picture. Every cell has antigens, but abnormal cancer cells will develop their own unique abnormal antigen, their own unique surface protein that our body should recognize and then get rid of. But if it doesn't, then it's because it escaped immunologic detection by our body. So the immune system is always circulating, looking for bad antigens, right? It's always looking for hay fever, anaphylactic things, other proteins like bacteria that might go, oh, wait, you don't belong, we're going to fight you, right? That promote the inflammatory response. The lymphocytes are always checking, okay? This is the natural killer cells, the cytotoxic T cells, the B lymphocytes. We talked about that stuff in the process of inflammation. The cytotoxic T cells actually directly kill cells. They produce cytokines, the cytokines that cause inflammation. Natural killer cells are activated, and that will bring the tissue macrophages in to come in and do the Pac-Man thing where they phagocytose these other cells. The B cells will produce antibodies that recognize those antigens, so when they see them again, they fight them more. But some cells engage in immunologic escape. Either those antigens are really weak, or those cells produce something that suppresses our T cells. So sometimes we develop a tolerance to those antigens, and our immune system just kind of says, oh yeah, you were normal, but there's a lot of you, so I'm not going to fight you anymore. So we know that this immunologic escape happens with a lot of our cancers where we just don't recognize it, and the growth is allowed to continue. So let's talk about some of these antigens, tumor surface antigens. What we use them for is in diagnosis of cancer and monitoring the progression of the cancer and seeing the cancer's response to chemotherapy, radiation therapy, or other therapies that we've used. Some tumor antigens can be blocked. They'll develop a blocking antibody that keep our T cells from destroying them. So that's a tumor escape mechanism that the cancer cells themselves can create. They'll develop a blocking antibody that covers their own little antigens, so our cytotoxic T cells won't recognize it, won't come along and kill it. Okay, so the antigens on the surface of the cell. Let's see, we already talked about most of this. They result as the cell reverses its course, becomes less differentiated. We don't understand why these fetal antigens develop, but we know that it happens. So two of the most common ones we see out there are CEA, carcinoembryonic antigen, and alpha fetoprotein. CEA is present in a lot of cancer cells, but it's most commonly, we see it in the GI. The colorectal cancers often have an elevated CEA. So colon, liver, and pancreatic cancers. The alpha fetoprotein, fetal antigens found in liver cancer, quite commonly in liver cancer. Some other oncofetal antigens, CA125, CA19-9, prostate-specific antigen. Some of these are seen with ovarian cancer, with pancreatic cancer, prostate cancer, KRAs, HER2, that goes with breast cancer. So these are antigens on the surface of the cell that have developed as that cell has become less differentiated, reverted back to its fetal or stem cell, reverted back to its, I could be any kind of cell origins. So how do we classify cancers? We talked about initiation, we've talked about promotion, we've talked about metastasis, we've talked about identifying cancers on the basis of the antigen on the surface of the cell. But when we need a classification system so healthcare providers can talk about this cancer, we can all understand what we're talking about when we talk about that cancer. So we classify cancers by either their anatomic site, and that is in how we name it, the histology, so how that cell looks under microscopic evaluation, and then we also stage it by how extensive the disease is, how far it's grown and progressed. So again, we use it so we can communicate better together, so we can develop a treatment plan that makes sense to all of us. And sometimes it can help us with prognosis. What's the outcome going to be? We can also statistically compare groups. So what was a stage 4 carcinoma like for all of these patients? So anatomic classification. You're going to hear this in the naming of the cancer. A carcinoma, when we call it a carcinoma, it's going to be a cancer that's come from skin or glandular tissue or the mucous membranes along the respiratory or GI tract. That's going to be called a carcinoma. A sarcoma is going to come from connective tissue, muscle, bone, fat. And a lymphoma or a leukemia are going to come from the blood cells, the plasma cells and the blood cells. That makes sense? Carcinoma, mucous membrane linings, especially respiratory and GI tract. Sarcoma, connective tissue, muscle, fat, bone. So if I have a tumor in my muscle, it's going to be my bone, it's going to be an osteosarcoma or a myosarcoma. If I have blood cell cancer, it's going to be a lymphoma or a leukemia. If I have GI tract cancer, it's most likely going to become a carcinoma. So the histological classification then is going to talk about how closely that cell resembles its parent cell. So poorly differentiated cells are bad. Highly differentiated cells are good. If it looks like a GI tract cell and it acts like a GI tract cell and it grows like a GI tract cell, then it's a highly differentiated cell. If it doesn't look or act like a GI tract mucous membrane cell, then it's a poorly differentiated cell. There's usually 4 or 5 grades, depending on which grading system your particular agency is using. Grade 1 looks a lot like the parent cell. Grade 2, a little more abnormal. Grade 3, pretty abnormal, and they're not acting well. Grade 4, they're immature, primitive, highly fast growing, and we can't even tell what it originally was. It doesn't look and act like the original parent cell. So grade 4, bad. Grade 0 or 1, good. Then we stage our cancers. Okay? So we had grading, now staging, okay? Stage 0, it's cancer in situ, which means it's confined to the cells of origin only, just a small little regional group of cells that hasn't grown out, it hasn't invaded any surrounding tissues, it's just in those cells of origin. 1 is limited to the tissue of origin, so it's not just in that little small pocket, it's moved into the tissues, but it's around that little cell. So in situ, just in the mucous membrane lining. Limit, and then if it's a 1, it might be in the GI tract around it, but it's just right there at that site. 2, it's got local spread throughout the site. 3, it's more extensive local spread, and 4, it's metastasized to other organs. So we've named it through a classification system, and then we've graded it, and we've staged it, okay? The TNM classification syndrome is one of the most common ones used in our country, so you kind of need to be familiar with what it means. The T stands for tumor, size, and invasiveness. The N stands for lymph nodes, has it spread to the nodes, and M stands for has it metastasized to other organs. So here's a picture explaining that. T could be a 0, T1, T2, or T3. Tumor, remember tumor size and growth. You can see T0, it's in situ, just the stages of the cells of origin only. T1, just there in that little local tissues. T2, it's more expansive. T3, it's starting to metastasize. It's burrowed beyond the cells of origin, the tissue, the original tissue, through the cell walls, through the tissue, the encapsulated tissue around that cell, that organ, and it's spreading. And it's not in the lymph nodes, so it could be N0, or it's in one lymph node. 2, it's in more than one lymph node. N1, it's in one lymph node. N2, it's in more than one lymph node. Metastasis means it's not metastasized, 0, there is no metastasize. M1, it's in one other organ. M2, in more than one other distant organ. So classification, grading, staging, right? You know the words, you know the terms, you'll kind of understand what it means now when you sit on the lab report. So primary prevention is what we always talk about when we talk about new diseases. So how do we reduce our risk of cancer? The number one thing we have to do is eliminate the exposure to carcinogens. Don't smoke. Use sunblock if you go out in the sun, or cover up. Eat a well-balanced, healthy diet rich in antioxidants. Exercise regularly, and get lots of sleep, adequate sleep, not lots, but at least 6 to 7 hours a day. 8's better. So have regular health exams. So this is going to be early detection. Regular health exams don't prevent cancer, but they do detect it early. We also want to change our perception of stressors. Stress is a big carcinogen. So if we can alter how we perceive our stressors and respond to them differently, then that can help improve our immunologic surveillance. Know your 7 warning signs of cancer, that caution acronym, so that we can recognize symptoms early. Get your regular cancer screenings. Get a pap smear once you become 21 or sexually active. And then if it's normal, you can go to once every 3 years. If it's not anything suspicious, then we're going to have more regular pap smears. Some doctors require them to get your birth control pills, but the CDC does not mandate an annual pap smear. We do want to practice breast self-exam, testicular self-exam, skin self-exam. If you suspect anything, seek out medical care. Other recommended cancer screenings, I mentioned skin surveillance, breast self-exam, and testicular self-exam. Those are the three major self-exams. But other cancer screenings, going to your dentist every 6 months for a good oral exam, at least a thorough oral exam annually. Go to your dentist every 6 months for the cleaning, but an annual oral exam is very important. How about things like a colonoscopy? After you get to 50, you want that colonoscopy every 5 years. Those kinds of things. Diagnosis of cancer. Somebody gets that diagnosis. Well, we found it, we've detected. They need to understand what their classification, staging, and grading is. What's it mean? What do the words mean? It's scary terminology and it's overwhelming for a patient. So be very clear in your explanations. Help that patient understand that terminology and know what it means. Give them written information on their kind of cancer, what the Cancer Society says. Actively listen to what they're worried about. They're going to be fearful. They're going to be asking you questions. You want to let them ventilate and verbalize that fear. They ask you a specific question. You want to address that question. A lot of anything about diagnosis and prognosis, we need to make sure the provider has talked about them first, because diagnosing and prognosing are things that belong in the world of medical providers, the nurse practitioner, the PA, the doctor. But we want to reinforce, educate, and help them move on. Remember, nurses deal with the holistic patient, the rest of the patient, how they're going to respond to that, how they respond to the stress, how they're going to adapt their home life, helping them with dietary changes, helping them with lifestyle changes. So actively listen and address their concern. Is it hair loss? Is it nausea? Is it loss of function? Is it not being there for their kids? Reflect back, deal with what their concerns are. Our plan always has to take into consideration what's that patient's health history, what's their background, what their risk factors are, what we found on their physical exam, and what the diagnostic tests showed. So the diagnostic tests are going to depend on what their presenting symptoms are, right? One of the most common diagnostic tests is a biopsy. I believe this is the end of this slideshow because we're going to be moving into diagnosis and follow through. But we're up to the initial thing. One of the most common things we do to diagnose, not just lab work, not just x-rays and MRIs, we can do a biopsy where we actually take a piece of the tissue and examine it under the microscope so that we can stage it and grade it. So biopsies can be done by needle. We can get a core biopsy with a needle. We can aspirate fluid and cells through a needle biopsy. We can do an incisional procedure where we cut into that tumor and take some cells. Or we can do an excisional procedure where we take out the whole abnormal mass and then send it to the lab for further evaluation and analysis. So biopsy, a needle biopsy, an incisional biopsy, or an excisional biopsy. Excisionals can be more extensive surgery. We remove the entire abnormal mass. Incisional, we really removed a piece of the mass. Needle, we just stuck a needle in it and aspirated or took a few cells out. All right, that's the end of this slideshow. We're going to move to the next PowerPoint.